Hi everyone, thank you for joining. We'll be starting in the next very few minutes. Hello, good evening everyone. I hope you can hear me. Paul, kindly confirm whether you can hear me.
Can hear you.
Okay, thank you so much for that. So allow me to begin this session, and I wish to thank all of you for joining. And apologies for last week, but thank you for even keeping time to join today. Our speaker today is Dr. Nafula. I will introduce her and then I will hand it over to you, Dr. Nafula. So Dr. Nafula is a pain care specialist based at Kenyatta National Hospital, where she heads the pain and palliative care unit. She's passionate about palliative care, and she's involved in making services and education available in Kenya. She has vast experience in various setups, hospital community and hospices. She's a fellow of the Institute of Palliative Medicine, Kerala. She holds a Master's of Science and Diploma for Higher Education in Palliative Care from the Oxford University. She also holds a certificate in teaching and learning for higher education from the same university. And she holds a bachelor's degree of medicine and she holds a Bachelor of Medicine and Bachelor of Surgery degree from the University of Nairobi. Her roles include clinical care of patients and family, teaching and mentoring various palliative care programs for healthcare providers, and advocating availability of opioids. Dr. Nafula is passionate about making palliative care services available to the vulnerable groups, including children and persons living with disability. She's a member of the Board of Trustees of the International Children's Palliative Care Network, that is ICPCN, and she's also a council member of the Board of the Public Health Palliative Care Initiative. So as you can hear, Dr. Esther has vast knowledge in palliative care and pain management. And I hope you have your notes and pen taking notes. And I wish to hand it over to Dr. Nafula. At the end of the session, we'll be taking Q&A. So kindly write it on the Q&A. You will also have an opportunity at the end to ask questions. So you'll just lift up your hands towards the end. Thank you, and over to you, Dr. Nafula.
Thank you for the warm introduction. I hope you can hear me. So I'll start sharing the presentation. In case there is any challenges, let me know.
We can hear you, Doc.
And I hope that by the end of this session, you will learn something new. So the objectives of the session is to discuss methods of recognizing and assessing pain in children, to look at the developmental and behavioral approach to assessing and treating pain, then to look at some of the interventions that we have, pharmacologic and non-pharmacologic, and to understand the importance of discharge planning and transition of care. Now, pain is a very common complaint among children. And when dealing with children, it's not the same as adults, because sometimes it is hard for children to communicate to us that they have pain. There are many factors that we are going to look at that make it hard to manage pain in children. When a child presents to us in an emergency room with pain, there is disruption of the flow of service, because a child in pain will actually come screaming. Their family members are very anxious, they want attention immediately. Therefore, we need to recognize and effectively manage the pain so that we improve the outcomes for the child and we provide family-centered care. Many studies have shown that medical providers underestimate pain, especially in children. There are some myths that very young children do not experience pain. And even in practice, it is very common to find that we ask the parent or the caregiver about the child's pain instead of actually asking the child, even when the child is old enough to communicate about their pain. And inadequately treated acute pain may lead to chronic pain and also leads to negative emotional experiences for the child. They end up associating the hospital with pain. Very many times we need to carry out procedures that may be painful in children. This include things like reduction of fractures or orthopedic procedures, carrying out wound debridements, inserting chest tubes, removing foreign bodies, repairing lacerations, draining abscesses, even just fixing an IV line or drawing blood for lab procedures. These are painful procedures for children. So many children with chronic conditions will present with pain, and these are the children that often need palliative care. So some of these conditions are life-threatening and some are life-limiting. So the life-threatening conditions are those that can be treated and there's a high chance of recovery, but sometimes the children fail to recover. And a life-limiting illness is a progressive illness that is likely going to lead to death. So we have diseases like cancers. Some of them fall in the life-threatening category. Then we have children with sickle cell. We have children with rheumatological disorders, children with progressive neurological disorders that will present with pain. So chronic disorders, sometimes patients have chronic pain. These children, for example, children with sickle cell may grow up experiencing pain a lot in their lives. So their experience and their rating of pain is quite different from maybe a child who has just had a fracture. Then adolescents also have very special issues because they are able to communicate, they're starting to have an identity, and they want to be involved in their care. Postoperative pain is also common in children, but today we are going to look just at the principles of chronic pain because that is the domain of palliative care. Now, children respond to painful stimuli depending on a lot of things. The age of the child greatly determines how they will respond to pain or how they will verbalize their pain. Very young children, less than 2 years, are not able to communicate. They have not developed language. So for them, what they do is to cry and scream when they're in pain, and they seem agitated, and often the caregiver will try to comfort the child. They will try to make the child comfortable, then conclude that maybe the child is in pain, or they may see that when they touch a certain area of the body, the child feels pain. Now, when we look at other factors like gender, ethnicity, socioeconomic, and cultural issues, the children are cultured by adults. So the environment of the child greatly affects how this child is going to talk about their pain. We have some cultures where children are to be seen and not to be heard. So that's a child who will likely communicate their pain through their parent or their caregiver. And we have other cultures where children are allowed to express themselves freely. So a child from a culture like that would easily tell you, I'm in pain. Genetics, depending on which disorder we are dealing with, because sometimes we are dealing with genetic disorders where there's an altered sensation to pain, it could be heightened or decreased, will actually affect the experience of pain. Then for older children, what has been their previous experience with pain? What is the worst pain they have experienced in their life, and how was that pain treated? Did they come to hospital and get injections or a painful procedure? Because again, that is how they relate the pain they're feeling to their past experience. So when you ask them about pain, they would think the worst pain I have experienced maybe is a fracture. So they think about the pain they're having now and compare it to that fracture. Then the patient and family perceptions. So children are very impressionable. They look at their parents, they see the reactions of the parents. So a child who is in pain with an anxious parent will actually experience the pain more because they can see from the body language of their parent that or their caregiver that there must be something serious going on. So it's good to have this at the back of your mind when you're going to deal with a child. When you're going to assess pain or manage pain, it's good to think about some of these factors that you need to consider when taking your history or even doing your prescription. Now, people think that children do not have memory, they do not remember. So when we're doing procedures on them, the aim is usually to give an intervention that is going to cause a positive effect. But sometimes we do not remember that the children have memory. They start creating memories from as young as 3 years. So what we do when a child has pain has lasting effects. So recurrent pain could mean that we are having undertreated pain. We have not isolated the factors around this pain properly, and we have not given interventions to relieve this pain. Then we have developmental factors. So this includes the age of the child, their coping mechanisms, at what stage of development are they, what is their past experience with pain in hospitals, and this is what actually creates a pain memory. So we have children who will come and tell you, this is not my first time to have pain, and the last time I had pain, I was given an injection. And there are some who will not communicate because of the experience that they had when they had pain. So they remember, I came to hospital in pain and I was treated with a more painful procedure when I said I had pain. So all this influences how they will rate their pain and affects how we will assess pain in them. So the first thing we want to look at is recognition and assessment of pediatric pain. So the first step is to recognize or anticipate pain. That is where we start. So sometimes during the history taking, you'll be told this child has this diagnosis or this child has been receiving this treatment. So already you start to think and anticipate that this child has a condition that is likely to cause them pain. So sometimes for very young children, they cannot tell the difference between pain and anxiety. And as we've mentioned, there are very many factors that will affect how the child talks about their pain. So we need to look at their nonverbal communication. We need to look at their body language. We need to look at how the child is interacting with us, with their caregiver, and with the environment. We can actually draw a lot of conclusions from that. Additionally, procedures and treatment sometimes that are used to treat pain or manage disease or injury may actually induce pain. So there are 4 things that we are going to look at in pain assessment. First is to assess the physiological parameters, then to look at the behavior that is observed, then to question the child, then look at which tools are we using to do this assessment. Now, when it comes to the physiological parameters, first we start, of course, with a physical exam. In the event that a child presents to us screaming and there is pain, we need to manage the pain first before we start taking a comprehensive history, because sometimes this history could take you half an hour, 1 hour, and you have a screaming child in pain. So first is to just quickly try and ascertain where the pain is, what could be causing the pain, and then which interventions are good to manage the pain as you take a good history and physical examination. So when there is acute pain, sometimes we have some physiological changes. This could include tachycardia, tachypnea, raised BP, desaturation, dilated pupils, flushing, or pallor. Now, the next thing is to look at the behavior of the child. We want to observe and recognize pain. What is the nonverbal communication of the child? What is the child telling us with their face and their body language? Are they grimacing? Are they having facial expressions that tell us they have pain? Are they cringing their muscles? And this is very helpful, especially for children who are nonverbal, either because of their medical condition or because of their developmental stage. The caregiver can also tell you that this child's behavior is not normal. Normally the child is calm, now they seem to be agitated, can see the face muscles. Sometimes it's very easy to tell that someone is in pain because you can pick out the discomfort just by looking at them. But sometimes you also need a report from the caregiver. So learn how to observe the pain by the development. The infant is going to be screaming. The toddler might avoid doing some things. The preschooler could talk to you. And the older children who are also school age and adolescents will point out and say, my arm hurts, my tummy hurts. So we are going to go through each of these developmental stages and look at what is special about assessing pain in these developmental stages of the children. Now, infants are nonverbal. So we observe their behavior. As I mentioned earlier, sometimes it's a lot of trying to put them comfort. So it's elimination. You look at, is the child hungry? Has the child soiled their diaper? Then is there an area that hurts? Why is the child just crying? They're not feeding, they're crying. So when we are performing an infant behavioral observation, we look at their facial expressions first. So how is their face? Is the child smiling at you if they've achieved a social smile? Are they frowning? Are their muscles tight? Are they, have they shut their eyes? Are they crying? Then look at their muscle tone. What is their activity? Is the child relaxed? Or are they guarding? When you try to console the child? Is the child able to be consoled or not? Then there is poor feeding and poor sleep quality. So most infants, when they're with the caregiver or their parent, when the parent consoles them, they relate to the comfort and the reassurance, and they will stop crying. When a child is still crying, even some of the scales that we use to rate pain in infants, we look at those areas. What is their facial expression? What is their activity? Are they able to be consoled when they're crying? And generally, what is their behavior like? In the toddler, sometimes the toddlers have started to say 1 or 2 words, and they're able to tell you this hurts. They're able to say some syllables, but sometimes we look at their behavior. They could be angry, they could be throwing tantrums or just regressed. Again, their facial expression and their activity of their muscles will tell you. And sometimes they don't want you to touch a certain area. They might sit in a position that does not look very comfortable to you, but that is their most comfortable position. They could be irritable, crying a lot. They have poor feeding and sleep quality, and they're really restless or just unusually quiet. So be very observant about these very young children, and the parents bring them in and listen to what the parents are saying. Because sometimes children are brought to us and the parent is concerned that my child is down, my child doesn't seem to be relating to us as normal, is refusing to feed. Some of this could actually be signs of pain. When you do your physical examination, you might actually find an area that is very tender. In the preschoolers, again, when we are looking at observation, remember these scales are important because a child will tell you about their pain, but we've talked about some factors like their age of development, their previous experience with hospital, their culture. So sometimes they might not verbalize the pain. So you actually need to observe them. As you're taking the history, also observe how is this child behaving. So the preschoolers might be having stalling or delaying. They might be giving you explanations because they're at the stage of magical thinking. So they could be giving you explanations that are not really making sense, but they're trying to communicate that they have pain. Again, some of them get withdrawn, and still we look at their facial expressions. That is the giveaway when someone is in pain. Their activity, irritability, any changes in appetite or sleep quality. The older children are actually able to tell us about their pain, but when we want to use an observational scale, because some of them might be nonverbal, the principles are the same. Look at their facial expression, look at their activity. Are they gagging? Do they seem comfortable? Are they irritable? Are they crying or producing sounds that depict that they have some discomfort? Explore the location of the pain, the duration of the pain, quality of the pain, precipitating factors, effects on daily activities, pain relief measures, and previous pain experiences. So this is where we question the child, where the child is able to talk to us. So we want to ask them, where is your pain? When did it start? How does it feel like? Please describe it to me. Are there things that make it better or worse? Are you sleeping well? Are you eating well? Have you ever had this pain before? And the emphasis is that you should ask the child first before you ask the caregiver. So consider using the child's primary language if you know it. Sometimes the primary language could be their native language, so you might need their parent to ask them. Words or phrases suggested by the parent or caregiver that are phrases that could be referring to pain, and then the developmental level of the child. So remember to come down to the child's level, relate to the child. Do not tower over them. Try and be at the same level with the child, be friendly, interact with the child, reassure them, let them feel a sense of safety around you. Let them trust that you are doing things in their best interest, so that when you ask these questions, they're actually able to answer truthfully. And remember, please, that children are very perceptive. So when we tell children, for example, I'm not going to inject you, and then Soon after you finish assessing their pain, you come up with an injection. That's how you start destroying the child's trust in the healthcare providers. So the next time they come, they know, I will say I have pain and I'm going to be pricked. Try to be honest with them. An older child might ask you, are you going to prick me? If you're likely going to prick them, please say yes. And reassure them that the prick is going to make them better. The prick is not meant to hurt them. So some of the things that make children not disclose their pain is because they want to avoid painful treatments. They know the last time I said I had pain, then I saw 3 or 4 adults come to hold me down. One was pulling my leg that side because I had a fracture. Some fear being sick. They want to be home as much as possible. They fear healthcare professionals because they know you don't have good news whenever you come around them. Then depending on their age, some of them feel guilty for being sick, so they want to protect their parents. Especially, remember I mentioned sometimes parents come and they have anxiety. So the child observes and knows that whenever I'm in pain, my mother is very distressed. So the child wants to protect the mother from the distress, therefore they will avoid talking about their pain or they'll underrate it. They want to avoid being in hospital as much as possible, and sometimes they also want you to discharge them from hospital very quickly. So when you ask them, do you have pain? They tell you no, and you can see from their facial expression that they do have a lot of pain. Children with special needs also experience pain. So some of them, their special need could be a learning disability, so they're not able to understand or respond to you. So adopt the techniques of asking about pain to the child's ability to understand and respond to you. And where this is not possible, let the parent or caregiver describe to you what their communication abilities are or how they communicate with the child. Let them describe to you what they have observed that could be indicating the patient has pain. And then what measures they use usually when the child, for example, is agitated. For example, if you're dealing with an autistic child, you're dealing with a child with cerebral palsy, what are the measures or interventions that the parent or caregiver takes to keep this child comfortable? Now we want to talk about the tools a little bit more. So we have standardized tools for assessing pain in children, and these tools are based on the age of the child, the cognitive ability of the child, the condition of the child, and sometimes the preference of the institution. Now, the rule of pain assessment tools for children is that you should use the same scale throughout the hospital experience. Now, if a child has come and we are using the numerical rating scale, let us use the numerical rating scale throughout the hospital period. In case we need to change the scale for whatever reason, because a child could come in communicating and their condition could worsen and now they cannot communicate, so we need to move to use a behavioral scale. It is good to document why we are using a different scale and then continue now with that different scale until a time when we have managed the pain. The scale that you're going to use to manage pain, please educate the child, the parent, or the caregiver about that scale. Explain to them this scale is for assessing pain in order for us to be able to manage the pain effectively. This is how the scale is used, and we're going to be using this scale every time to reassess the pain as needed. So some of the tools that are there are very many, and this lecture is an overview generally of pain management in children. We will have another session of pain assessment tools and we can go through them in details, but we have scales that we use from birth to 6 months, and most of them are behavioral scales. So the commonest is NIPS and CRIES, and the neonatal facial coding system. So this one's observe the behavior of the child, and the score again is from 0 to 10, where 0 is no pain, 1 to 3 is mild pain, 4 to 6 is moderate pain, and any score above 7, above 7 is severe pain. Then for the infant and older children who are nonverbal, we have the FLAC scale, and we have some checklists also for non-communicating children. So there's a pain checklist where you look at certain behaviors. As we mentioned, there's always the behavior of the child, the facial expression, the cry or consolability, the activity. So you look at those things and you will put a mark that corresponds to what you're observing, and then you give a score. Now for children who are 3 years and older, so those who might not be going to school but are above 3 years, we have the Wong-Baker Faces Scale, which has faces. It's in one of the other slides, we'll see it. So the faces move from a calm, smiling face to a crying, inconsolable face. And again, the child picks out the face that corresponds to their pain. 8 years and older, these are children, especially the ones who are going to school, they're literate and they know how to count. They can actually rate their scale using a visual analog scale to tell you it is mild, moderate, or severe, and they can also use the numerical scale to pick a number that corresponds to their pain. Now we are moving to the types of pain that are common in children. So it is very important to identify the type of pain that a child has, because this again affects our choice of analgesics. So pain is classified in 4 different ways. And the first is by the etiology or the cause of the pain, where we can classify it as nociceptive, inflammatory, neuropathic, or psychogenic. So what is the mechanism of the pain? Then we have the anatomical location. Is it somatic or visceral? Which body organs seem to be affected by this pain? Then is it acute or chronic, or is it acute and chronic, exacerbation of chronic pain? So that is based on the duration. And the cutoff for acute and chronic pain is 3 months, because that is the period of normal healing. So any pain that has lasted more than 3 months is considered to be chronic pain. Then we also rate pain or classify it based on the intensity as mild, moderate, or severe. Now, there is a tendency to have mixed pain in palliative care. So when a patient presents with pain, it might not be purely nociceptive or somatic. It might not be purely acute, mild. So it is good to be aware of these classifications. These help you to understand the pathophysiology of the pain, so that you pick out the analgesic that is going to work for the pain. For example, a child with a fracture and a child who has a tumor in the bones, their management of pain will be very different. These are 2 illnesses that are affecting the same structure, but then the pathophysiology of how that pain is transmitted to the brain and how it comes back and is interpreted as pain is very different. So the treatment again ends up being different. A fracture is an acute pain. The pain is likely going to subside as the fracture heals. A tumor is a chronic pain. The pain is unlikely to subside even with treatment, because this tumor is going to infiltrate on nerves, and as we continue with treatment, some of the treatment also results in pain. For example, if it is malignant and we are going to give radiotherapy, we might also be causing more pain. So treatment options are pharmacological and non-pharmacological. So pharmacological are drugs, and then non-pharmacological are other interventions that will make the pain experience better or lesser for the child. So we'll start with pharmacological. They are the tough ones, but we'll start there. So I'm going to go through 4 strategies for managing pain in pediatric palliative care. And the first is by the root. So when we are choosing a painkiller, think about it. How long is this child going to need this painkiller? What is the efficacy of the medication? What is the half-life of this medicine? What are the side effects? Am I going to cause more pain to try and relieve pain? So we try to use the least invasive methods and the most effective agent. So we prefer oral or nasal routes in palliative care. IV, we reserve it for moderate or severe pain where the child is not able to swallow or is vomiting and we are not able to control the vomiting. Intramuscular and rectal routes are very uncomfortable, so we avoid them as much as possible. But in some certain instances, we might be forced to use those routes. So when choosing medication, think about it. What is the severity of the pain? Which medication is available? Which one is the best under the circumstances? By the clock, we want to give medication at the correct intervals. Now, our prescriptions or drug packets in Kenya are commonly written, for example, for a child, take this syrup, 5 ml of this syrup times 3. So what happens? You might find that the child is given the medication at 8 in the morning, at 1 p.m., then at 9 p.m., because this we coincide it with meals, breakfast, lunch, and dinner. But that medication was meant to be given 8 hourly. That is not 8 hourly. 8 hourly medication should be given at 6 a.m., at 2 p.m., and at 10 p.m. Now, in order to have good pain relief, we need to give timely and routine dosing. Start with the dose that matches the pain. So if it is moderate, mild, or severe, start with the correct painkiller and then titrate the dose upwards. And let the medication be given at those specific time intervals so that when we need to modify the dose, in case the pain is not reducing, then we are able to calculate the demand of the child. For example, if we've been giving, let's say, paracetamol 8 hourly, we want to increase it to 6 hourly, or we need to increase the dose because the dose in children is 10 to 15 milligrams per kg. Now, let's say we started at 10 milligrams per kg and we were giving every 8 hours. The maximum is 15 milligrams per kg every 6 hours. So when we are titrating the dose, when the medication has been given by the clock, it is very easy to move upwards or to switch to our stronger painkiller, because sometimes the pain is not getting relieved because the medication is not being given correctly. It is not being given at the correct doses at the correct times. Then by the child. What does that mean? Think about the child whose pain you're managing. What is the developmental age of the child? What does the child understand about their illness? What are some of the cultural influences, religious beliefs, preferences of the parents or of the child? Sometimes we are here giving children syrups and they think they're old enough to take tablets. Have you talked to the child? Are you giving them 6 tablets in a day, trying to manage pain? Is the child comfortable to take 6 tablets in a day? You've kept a child in hospital 3-4 days trying to manage their pain. Is the child comfortable in hospital? What about the family setup? Who is the support system of the child? What do the parents believe about the illness? Because sometimes we are prescribing your morphine and the parent believes that my child has been bewitched. So what do? They withhold the morphine. Or they believe morphine is given only to dying people. So they see morphine and they say, no, my child is not dying. So they withhold the morphine. So it is very important to individualize your treatment, understand the factors affecting that child whose pain you want to treat, so that you can actually treat their pain effectively. Then lastly is by the ladder. So World Health Organization in 1980 developed a 3-step pain relief ladder. Originally, it was meant for cancer pain, but these principles we are discussing actually come from this WHO analgesic ladder. Have been used in many different patients with chronic pain, and the success is over 80%. That when we use these principles, 8 out of 10 children's pain will be relieved. So what this ladder recommends now pharmacologically is that we choose the medication that corresponds to the degree of pain. Now, the children's ladder has 2 steps. For mild pain, we use NSAIDs, which is paracetamol and brufen. Then moderate to severe pain, we use strong opioids like morphine. And the reason for that is because when we are using weak opioids, that is tramadol, dihydrocodeine, especially to manage chronic pain. Children are not able to metabolize the weak opioids well, so they accumulate the metabolites and tend to get more side effects from them. But that does not mean that we cannot use them, especially for a short time. In illnesses like sickle cell, we can actually use the weak opioids to manage a crisis. For cancer pain, we are going to use opioids for a long time, so morphine is the preferred option. Now, this ladder also encourages us to use multimodal analgesics. So that means we try and combine different medications. We combine opioids and the NSAIDs. Then we use adjuvants like anticonvulsants, steroids, antidepressants, depending on the child's age to manage their pain. So strictly speaking, if we look at the categories of drugs that we use for children, we have topical agents. We have local anesthetics. This could be for nerve blocks or regional blocks. Then we have mild analgesics, which is where the non-steroidal anti-inflammatories fall. Then moderate, we have weak opioids, and then we have strong opioids. So for severe pain, our preferred analgesic in Kenya is morphine. And sometimes where there's intractable pain that cannot be managed by the morphine, we do have our anesthesia team that can assess the child for a nerve block or an epidural infusion. Now, pain management does not stop at prescribing painkillers because children are children. They like to play. They like to be active. So we need to remember that non-pharmacological interventions have a very big role in managing children's pain, and some of it includes play therapy, guided imagery, distraction techniques, and we'll look at some of them just shortly. So when we prescribe medication, let us also think about the other things that can improve the patient's pain. Can we encourage the child to play? Can we use comfort positioning? These are very good interventions, especially for the toddlers, where the parent will hold them during procedures. So they could hold them, swaddle them, bear hug, back to chest, or side sitting. So these are positions that reassure the child that the caregiver is with them. So the child gets comfortable with the procedure you are doing. Distraction techniques, of course, are very good because the child will concentrate on playing as you're doing your procedure, maybe drawing your blood or fixing an IV line. So we have techniques like music, blowing these blow bubbles, distraction boxes, and toys that have been used to actually help the patient to stop concentrating on their pain or on the painful procedure that you want to perform and cooperate with you. Guided imagery is good for the preschool age. The children who are imaginative, you help them to use their imagination to think of their favorite place, the thing they want to do most, the food they want to eat. So as you're talking about this experience, the child is imagining what it would feel like if they went back to Mombasa, to the beach. So it gives them a more pleasant experience when you divert their thoughts, and they'll actually be more cooperative the next time you come to assess or reassess their pain. Now, reassessment of pain, how often should it be done? It should be done as often as needed, because the common mistake we make, a child comes screaming, we give them opioids, their pain goes away, then we do not reassess until the next time the child is screaming is when we want to reassess. So it is good to determine whether your interventions are making a difference, and we've said use the same pain score. Ask the patient caregiver and other members of the healthcare team what they are seeing before and after prescription of your interventions, and then look at the next steps in your treatment. And this is the Wong-Baker Faces Scale that we use in children 3 years and above. You can see there's a smiley face there, and it progressively moves to a crying face, someone who cannot be consoled. So I'm going to give you an overview of the stepwise approach of managing pediatric pain. Now, these steps can be used in assessing and treating any type of pain scenario in the pediatric setting. So we'll go through the steps and then summarize them. So the first step is to determine the situation or a situation checkpoint. What are you trying to accomplish or treat? Is there just pain? Is there pain and anxiety, agitation? Which procedures do you need to perform? Is this a chronic condition? Are we going to be dealing with this for a long time? So determine that through a history and physical exam or triage. So we are sort of trying to set our goals. So this patient has come in pain. What is our goal? To relieve the pain, to cure the illness, to restore function. What is our goal? Step 2, look at the developmental or cognitive checkpoint. At which age is the child? Is this a child who can communicate? Is this a child who can talk? Is this a child who can comprehend and understand what I'm saying? Can this child use a scale to assess their pain? Can this child tell me about their pain? Do I need to rely on their behavior? Do I need to rely on their caregiver? Then what are the family dynamics? Who is there with the child as you are assessing the child? Is it their parent? Is it their siblings? Is this an abandoned child? Is it a legal guardian? Who cares for this child? In the hospital, sometimes we find it's a relative, a brother who is stepping in for the parent. And when you discharge the child home, they're going back to the parent. So whom do you want as you're discussing about the long-term care of this child and future plans in case they need to go home with pain medications? What is the culture of the child? To which culture do they belong to? What do people in that culture believe about pain? What is the child's experience in the past about pain? What can they tolerate, if any pain experience exists, or is it the first time? Then what do the parents or the larger family believe is causing the illness of the child, or is the intervention? Because sometimes we prescribe medication, but they do not want interventions. Then facility. Which facility am I working in? What is the setup? Am I in a community-based facility? Am I in a hospital? What sort of hospital is it? A level 2, a level 6? Which kind of medication do I have? What sort of specialists are there in this hospital? Do we have an anesthesia team? Do we have a pediatrician? Do we have a palliative care team? So what is the expertise and capabilities? Do we have any policies on pain management? Do we have policies on handling opioids? Are the opioids accessible? And how do we prescribe them? How do we monitor them? Where is this patient coming from as opposed to our facility? Are we going to be referring them 300 kilometers away back home? Then which equipment do we have? Are we able to monitor? And what are the alternatives? The next checkpoint is the patient assessment. So look for risk factors from your history and physical exam. And these are risk factors for illness or for adverse reactions to the analgesics you might want to prescribe. Look for any chronic illnesses, psychiatric and mental considerations. Then if the child has injuries, what are the severity of these injuries? What is the weight of the child? What is the height of the child? Have they achieved their milestones well? For children, we calculate their medication based on their weight. So we really need to look at that. Don't just start prescribing 250 milligrams of paracetamol and you do not know the weight of the child. The child could be 1 year, but they're 10 kilos. It could be 3 years and they're 10 kilos. So prescribe by the weight. Now, step 6 is now your management checkpoint. What is your recipe? What are you cooking today? Are you making tea? Are you making coffee? Are you making ugali? So there's no recipe that fits everyone. You must individualize and adjust your ingredients. So look at it. Do we need topical? Do we need a local anesthetic? Do we need oral IV medication? What about the non-pharmacologic ones? What is available? Do you have toys in your clinic? Do you have toys in your ward that the child can play with? Are there toys that the parent has brought from home that are comforting to the child? Engage your caregiver, your parent, and volunteers. And where possible, you need a child life specialist, especially in areas that have a high volume of pediatric patients, because the child life specialists help us a lot with these non-pharmacological options, especially in children. Then the last checkpoint is now you've managed your pain. What is your plan going forward? Monitoring and discharging the patient. So at this checkpoint, the first thing is family education. Talk to the parents or caregivers. Ensure that you know where you're discharging the child to, who is going to take care of the child, what do they understand about the child's illness, educate them about their medication, the side effects, reassess the documents. If you need to give them any documentation to go home with, a patient's medication chart, a written discharge summary, take them through it so that they understand, because sometimes the follow-up will be done at a different facility from yours. If it is your facility, give them a proper appointment date before the analgesics run out. And the child should be back to what is their baseline. They should be tolerating fluids, not vomiting at the time you want to discharge them. Sometimes we've discharged patients and the parents say, I cannot go home with this sick child. The child is just as sick as they came, or even seems to be sicker. So please try to discharge home children who are stable and the parents are comfortable, that they understand how to take care of the child at home. Even when the needs are complex and we are not able to sort them out in hospital, let the parents understand that there's this level of care that we need to give at home. Are we able to give that care? And if we are not able to, yet we need to be discharged, what is the support where we are being discharged to? What is the nearest facility? Is there an emergency contact? What happens when this pain comes back? Whom do we reach out to? We're almost done. So in summary, this is the approach for effectively managing pediatric pain. First is to recognize and anticipate the pain, identify the type of pain, and this goes with understanding the development and cognitive age and development of the child. It also goes with understanding the family dynamics, the culture. Then choose the appropriate treatment, both pharmacologic and non-pharmacologic, based on what is available in your institution and the level of expertise that you have available to you. Reevaluate the effectiveness of your selected treatment and adjust accordingly based on the clinical course. And finally, as you discharge your patient, have a follow-up plan. What are we expecting? What is the outcome? And how are we able to support you? These are some of the resources that I used to create this pain presentation. Thank you so much. Today we are going to be looking at
Thank you for listening. We can now go to the Q&A. Dr. Weremba, back to you. Doc, we can't hear you.
Okay, as we wait for Dr. Weremba to come on board, thank you, Dr. Nafula, for your great insights. If you have a question, kindly raise your hand up. We are able to see you, and then we will unmute you. We are getting quite a lot of reactions. Thank you, Doc, for your presentation. Yes, a lot of thank yous for you. Doc, there was a question. During registration, someone asked, what is the best approach to dealing with cultural pain in families of children living with palliative care needs?
Cultural pain. I'm not sure I understand what cultural pain is, but when we when we assess pain in children, we still try to look at all the 4 domains in terms of the physical pain, the social issues around the patient, and the spiritual issues and psychological issues. So maybe cultural pain would come under the social issues. So I'm not sure what the participant means by cultural pain, but the way I'm understanding is cultural issues sometimes do come up. And one of the common ones is people wanting to see traditional healers before seeking treatment. Sometimes it's parents believing that their children have been bewitched and they want to withhold care. So a lot of it is usually ethical issues. And we try to understand where these beliefs are coming from, where the parents think the problem is. So you have to get to the root cause of the problem. So as we've mentioned, some cultures encourage children to talk. In some cultures, children and women do not talk. So you need a lot of cultural sensitivity to understand more about the dynamics of your patient to be able to assess and manage their pain well. Thank you.
Okay, thank you, Doc, for that. Wefafa, kindly ask your question.
We are not able to hear him.
Yeah, Wefafa, can you kindly hear us? I have made you a presenter. Or any other person with a question, kindly type it or...
Hello,
Yes, Wefafa, we can hear you.
you can now hear me. So I was
Yes,
saying,
kindly go ahead.
Yes.
you can now hear me. Yes, what I was asking is depending on what Dr. has talked about, the distraction during pain assessment and management, like you can include the issue of therapies. I was asking about the children, like they have been together in a hospital, like pediatric wing, they have been together for like 1 week, 2 weeks, 3 weeks, and one child maybe goes down and at the end of the day could not make it and can even pass on. So how we break the news to the remaining children become, because they had made a bond, it becomes an issue. How do we best handle that so that they feel like, shall we tell them mwenzenu amekufa ama what has happened, or how do we break the news to the children who are like close friends to them? How will they feel and how to manage that? That's my concern.
Yeah, thank you. That's a good question. Now, when we are having children, for example, in our ward setup, it's very common that one child could deteriorate and the others are watching. So communication with children, we need to communicate with them at their level and try to be as open to them as possible because they observe and they see. So for example, even when we are doing painful procedures in the ward, we are doing a bone marrow aspiration, we are doing lumbar punctures, and the children are just watching and seeing this one is being pricked and then you are coming to prick me next. It actually causes a lot of anxiety and psychological pain in the children. So it is important that we try and use we try and use different rooms for procedures where we can have some privacy. And then in situations where, for example, children die in the course of treatment, it's good to have a debriefing for the other children to try and explain to them or see what their level of understanding of what has happened is. So we do need a lot of open communication between ourselves, parents, and children as we are giving palliative care. Thank you.
Thank you.
Uh,
That's better.
okay, thank you, Doc and Wefafa. We have a few more questions. Someone is asking, how about spiritual pain assessment and evaluation? I can read it out to you, Doc, then you can answer together. There are three.
Yes.
How about spiritual pain and assessment? Spiritual pain assessment and evaluation. The other one is, what's the best drug or pain management for chronic non-cancer pain in children? And then, do children experience neuropathic pain and how can it be managed? You know, you talked about this, but if you would kindly share.
So the first question was about spiritual pain. Then the last one is about neuropathic pain. What was the second?
Best drug or management for non-cancer pain in children.
Okay. Now, spiritual pain. So spirituality is about meaning. It's about existence, what we believe gives us purpose in life. Spirituality also covers what we believe about illness, what we believe happens to us when we die or during the dying process. So children do experience spiritual pain depending on their level of development. We do have some tools that are used to assess spiritual distress or the spiritual issues. And maybe we could share this in the groups later on. There's a tool that the chaplains use to assess. So spirituality is not just about religion or about prayer, but it's about the interpretation of the suffering. So for children experiencing spiritual pain, some of the common phrases or statements that we hear is a child believes that they're being punished for being sick. So this illness is a punishment. Some children believe they have been bad, that's why they are sick. And again, based on what they've been taught or what they're imagining, because a lot of this also comes from our cultures and what the children have been taught, they would express what their anxieties are. So as we build rapport with them, remember we talked about building trust. So when children trust us, they're able to share some of these anxieties with us. So I know in some areas we do not have the luxury of having chaplains, and we probably might work with volunteer chaplains. So we might be the ones to pick out the spiritual concerns. So some children would ask you, am I going to die? What would happen to me when I die? So these are concerns that we like to raise with the parents so that whatever responses we are giving to the child does not conflict the belief system or what the child has been taught. So when you notice these concerns, it's good to share with the parents. Now, chronic non-cancer pain or non-cancer pain for children. Now, non-cancer pain for children, we use NSAIDs for step 1. So we use the 3-step ladder for non-cancer pain because again, most of it would be short-term pain. So we look at it this way. What is the cause of the pain? Is it curable or incurable? Now, where it's an incurable illness and we're expecting the illness to progress and the child to get worse, then we still use the principles of managing cancer pain. Where it is pain that is likely to recover, for example, it's a fracture, we will use the 3-step ladder to manage the pain. So if it is chronic pain and the illness is in any of the categories of palliative care, the focus is improving the quality of life. So we would still just use 2 steps where we move from NSAIDs to morphine. The last one is about neuropathic pain. Neuropathic pain in children is very hard to manage because a lot of the adjuvants that we use in adults, first line treatment for neuropathic pain includes anticonvulsants now and antidepressants. These drugs cannot be used in children who are less than 35 kg, which means we cannot use them in most children less than 13 years. So for neuropathic pain for children, the best approach is we give them the NSAIDs or opioids and then consider giving an intervention. So interventions would be nerve blocks, regional blocks. So that is what we use for managing neuropathic pain because we do not have a big choice where adjuvants are concerned. Thank you.
Okay, thank you so much, Doc, for your great insights. There's a question, one last question here, and I hope we have all asked our questions as this is the last one. I know we had a webinar on this previously, but in broad, if Doc, you can kindly answer this. How do we assess pain in neonates?
One minute. So neonates, children less than, what's the cutoff age? Neonates, I think up to, is it 8 weeks? So we use behavioral scales because infants are not able to tell us about their pain. So a lot of the time we are going to look at their behavioral, the way they're responding to pain. So we have the neonatal infant pain scale, and it looks at the facial expression of the child. Then it looks at whether the child is crying, how is their breathing pattern, their arms and legs, are they relaxed or are they looking agitated, are they raised, are they stretched, are they kicking around? And then the alertness of the child, are they sleeping, do they seem uncomfortable? So it's almost similar. The NIPS scale is almost very similar to the FLAC scale. So you would score, each of these things are scored from 0 to 2. So you look at when you look at the scale, for example, when it comes to crying, you'll have no crying, the child is crying or is very irritable. Then there's the facial expressions, extremities, their tones, and their vital signs. So the NIPS is there, and then also the FLAC. We can still use the FLAC scale for neonates because it's an observational scale. Thank you.
Thank you, Doc. And that's the end of our questions. I wish to thank you for your very insightful session. Thank you for making it and breaking it down and making it very easy for us to understand. And I pray and hope that it has made a difference to us as healthcare workers. And with this, I wish to invite our Executive Director at Kehpca, David Musyoki, to give us the way forward from here. Over to David.
Thank you, Emily, and thank you, Dr. Nafula, for a great session, and good evening, everyone. We are excited that despite the itches that we encountered last week, at least you were able to come in and join in good numbers. We were even more than, we registered more presence than we were last week. And I think that attributes to the statements or the thoughts that say sometimes all things work together for good. We've quite learned and we are grateful. So Kehpca continues to host different webinars every 2 weeks, and hence our next webinar comes after a week since we had to do this week. And the next session will be around non-pharmacological support or treatment of pain without using medicines for children with palliative care needs. This will be done by a child life specialist very vast, who has been doing this for many years. And I want to encourage you to join in and sign in so that we may learn. Probably you will need to do this kind of management at home or in your facility and in our different places. So karibuni. We also would love to hear from you and receive areas of need for various webinars. If you could give us those suggestions for topics that you would wish covered, we will be able to host. There is a suggestion for spirituality and cultural aspects for children. That's point of consideration. So use the different opportunities to engage with us and tell us the topics that you would wish we organize this kind of webinars. Thank you to all. Thank you to the Kehpca team who have been behind the scenes, making sure that we are well coordinated and that we run seamless. And so this brings us to the end of the day. I want to wish everyone all the best, even as we rest and as we undertake different other duties. Bye and all the best.
Bye. Thank you.